Good morning, everyone, and good afternoon from CBC Dubai. I want to take this opportunity to thank you all, and I would like to present our chairman, Ruda.
Good morning, everyone. I'm going to go silent for a couple of minutes while Zoom filters people into the webinar. We have a very exciting and a very exciting webinar ahead of us, and a very large number of attendees. So I'm very excited about how much knowledge sharing that will occur in this webinar. And I'm also excited about the topic because, as with most people, I have a strong level of interest and fascination with artificial intelligence, particularly as it regards to healthcare, but I don't know a lot about it. And so I am really excited, and I'm really looking forward to having this panel of experts tell us a little bit more about artificial intelligence and its applications in healthcare, and how it can really help impact health outcomes and improve the patient experience as well. My name is Ruda. I am the chairman of the Canadian Business Council in Dubai. And for over 25 years, the CBC has really focused on helping Canadians and Canadian alumni in the UAE and in Canada link with each other and share knowledge with each other so that we can all work together and succeed. And this has been especially important during the pandemic, when we were one of the first organizations to go into webinar mode, as it were. And we were also amongst the first organizations in the UAE, amongst the Canadian Business Councils and the National Business Councils, to really focus on making sure that all Canadians in the UAE and in Canada stayed connected and had a mechanism by which to share knowledge and connect with each other and really bridge the digital gap and make it more personal. Leading our webinar today will be Craig Chipatelli. Craig has taken up a role with the CBC Dubai, leading our Healthcare Connect group. One of our goals over the last year has been to focus on making our overall offering a little bit more focused on smaller groups of members to really encourage more knowledge sharing based on areas of interest and areas of career progression. And we call these initiatives Connect groups. We have a number of Connect groups. We have a Connect group focused on technology. We have a Connect group focused on entrepreneurs in the UAE, Connect group focused on legal professionals, and a number of others. And Craig is leading our charge with regard to healthcare professionals, helping them connect together and share knowledge and information with each other. I am very much looking forward to Craig moderating this discussion. Craig is a very knowledgeable and a very intelligent speaker and a very intelligent person. He is the executive director of the Office for International Collaboration at the Royal College of Physicians, and he provides strategic and operational oversight on the establishment of impactful collaborations with international organizations. Working with the CEO of the Royal College of Canada and International, he works to establish relationships with academic healthcare centers, ministries of health, and higher education, and all governing medical organizations internationally, all with the aim of improving postgraduate medical education systems in both the developed and developing world. It is an incredibly difficult challenge, and it is one that I am confident that Craig will succeed in. Before I sign off and cede the floor to Craig, I do have to take some time out to thank our sponsors, because of course, none of this would be possible without them. First, I'd like to thank our strategic airline sponsor, Emirates Airlines, as well as our gold sponsors, Legacy Emirates Group, as well as Galing WLG. And I would also like to take a moment to thank our silver sponsors in the form of Canada Health Infoway, Four Seasons Hotel, Hilton Hotel, and a number of others. Craig, I will leave the floor now to you.
Thank you very much, Ruda and Diane. Thank you all to those who have registered and are attending today. I believe we have over 300 registrants, and hopefully we'll hit that mark in the next few minutes. I want to go over some rules before we enter into the session discussion. If you have any questions, feel free to enter them into the chat box. We'll be monitoring that for questions. Hopefully we'll be able to answer all of them. If not, look into your inbox in the coming days and we'll provide some written responses. We're also recording the session, and there will be a link to the recorded session again in your inbox in a few days' time, so that you can come back and watch it or share it with your peers. This is meant to be an open forum, so again, please feel free to offer any questions you may have through the chat box. So our topic today is artificial intelligence and the impact on the medical profession, and specifically, how will artificial intelligence influence the training of health professions And how will patients benefit from the advancement of the introduction of AI and the delivery of care? We also want to look at how Canada and the UAE, specifically Dubai and the Northern Emirates, are positioned to have a positive impact on the advancement of AI in the health profession and the training and delivery of care. So many of you have heard of artificial intelligence over the last several years. It's dated back, I think the first reference was in the 1950s. However, the last 10 years or so, artificial intelligence has been gaining a tremendous amount of momentum in various sectors, and healthcare and education are no exception. Whether it's machine learning, deep learning, or robotics, or translation, AI has become an increasingly common topic amongst clinicians, educators, and administrators. Today, we're going to delve into AI's potential to improve healthcare, and we'll also address some of the challenges AI introduces to how we train professionals and how we deliver that care to those patients from a privacy and equity point of view. I'm going to take some time now to introduce our panelists, which covers the broad spectrum, in fact, from academia, from clinical practice, and the private sector. So with us today, and I'm going to have to read it, sorry for losing some eye contact with you while I go through this, but we have four panelists today. Dr. Vito Anese. Dr. Vito Anese achieved his medical degree from the Catholic University of Rome, and subsequently his certificate of completion of specialist training in internal medicine and gastroenterology from the same university. He also achieved the master's degree in medical sciences at the Université Catholique de Louvain in Belgium. He has over 30 years of experience in gastroenterology with specific interest in functional inflammatory bowel disorders. He's offered over 300 peer-reviewed publications. He is the head of gastroenterology at the Research Hospital San Giovanni Rotondo and at the University of Hospital Careggi in Florence. In addition, aggregate professor at the University of Foggia in Florence in Italy. In 2016, in the UAE, he's the first consultant gastroenterologist and medical director at the Valiant Clinic, and more recently as head of the internal medicine and gastroenterology department at Fahi University Hospital in Dubai. Dr. Anese also has a tremendous amount of experience using robotics and other data collection means through his clinical practice, which he'll enlighten us on. Ms. Jacqueline Duvoisin is the Senior Vice President at Think Research. Jacqueline leads the Middle East and African region. She focuses on world-leading clinical decision support tools and content, supporting health professionals to standardize care, to move towards practice evidence-based delivery of that care, and integrate these clinical data into their workflows. Jacqueline is based in Dubai and has 18 years of experience in the Middle East. She's involved in the clinical decision support product development, supporting the delivery and integration teams, and the marketing partnership growth at Think Research. And Jacqueline holds an MBA from INSEAD. Dr. Tanya Horsley. Dr. Horsley is an Associate Director, Research Unit at the Royal College of Physicians and Surgeons of Canada and faculty of the School of Epidemiology and Public Health at the University of Ottawa. Dr. Horsley leads an emerging program of research looking at the formalization of integrated knowledge translation for the co-creation, use, and influence of research in complex systems of care with a particular focus on multi-stakeholder engagement and organizational context. She is also dedicated to improving the standards for reporting research and has co-authored several internationally recognized reporting guidelines. And finally, we have Dr. Devin Singh, who is a practicing pediatric emergency medicine physician from the Hospital for Sick Children's, most commonly known as Sick Kids, in Toronto. He completed his undergraduate studies at the University of Western in Medical Sciences and went to work for the provincial government as a business analyst. He later attended medical school at the University of Sydney, Australia, with his pediatric residency in emergency medicine specialties training at Sick Kids Hospital. He also completed an additional fellowship in clinical AI. His research focused on the use of machine learning to solve some of healthcare's largest problems. He is the physician lead for clinical artificial intelligence and machine learning at Sick Kids for the Division of Emergency Medicine, and has recently obtained a Master's of Computer Science at the University of Toronto. Most recently, he has founded Hero AI, an innovative startup dedicated to empowering patients and healthcare providers with artificial intelligence. So I believe we have a very strong panel today to guide us through this discussion. I read a recent article, probably about a few months ago during the pandemic, and it stated that it was from the Health IT Analytics report. It stated that the pandemic has resulted in hospitals developing an AI strategy. And in fact, 9 out of 10 hospitals, they stated, have an AI strategy, with 25% of those centers already in the early stages of implementation. 75% of healthcare executives feel that AI strategy is a very critical issue, especially now given the impact of COVID and post-COVID response. So my first question is to you, Dr. Singh. As a clinician and an AI entrepreneur, how would you characterize the present state of AI on the delivery of healthcare today?
It's a great question, and thanks for the wonderful introduction. And on behalf of all the participants, it's an absolute pleasure to be here talking to everyone. So thank you for having us. So the present state of AI in healthcare, it's a really complicated question. I think your sort of prelude to the question around the pandemic bringing up this surgence of AI coming into hospitals, and hospitals are having policies and strategies now, I think is a nod to this idea that AI is meant to add capacity to systems. And there's aspects of clinical automation or workflow automation that AI can bring to a healthcare institution that really helps us add capacity. And certainly that's what the pandemic has challenged us to figure out, is how do we get innovative with our human workflows or technology workflows to create more capacity, because we're just simply overwhelmed at times. And so I think that's really interesting that then this pandemic is really highlighting the potential usefulness for AI. But what is the current state? I think it's quite variable. You've got a lot of academic institutions doing research and going from a data set, or trying to figure out, the big challenge is trying to figure out how do you extract your data from your electronic health record system. That's like a 1 to 2 year battle sometimes in and of itself if your institution hasn't done it before. And then once you go from data extracted out of that EHR system, you have this data set that is in often like an Excel file or a CSV file. And you have these academic clinicians and computer scientists building these models, asking questions. If I use this data, can I predict this downstream outcome? So an example in the emergency department at Sick Kids is we're actually using triage data of kids who come into our ED and trying to determine at the very moment after triage, can we predict what their downstream testing needs would be? And why would that be useful? Well, let's say a kiddo is on his bike and he falls off and hurts his arm. Everybody knows, even the parent, even the kid knows that they're going to need an X-ray of their arm. We all know this, it's so obvious, but that kid unfortunately will end up waiting 2 to 4 hours potentially to see a physician or a care provider like myself to then tell them the obvious, let's order that X-ray for your arm. And so we wondered, could we actually automate that process, right? And it turns out you can. Like, machine learning is so great at taking these sort of simple things that as healthcare workers, we can read a triage note and predict that that kid needs an X-ray. The kid can do it himself as well. And so machine learning can do that. And I think that's where ML and AI is currently at in a lot of healthcare institutions, is that we're figuring out the challenge of extracting data. We're thinking about interesting ways that we can integrate machine learning models into our healthcare operations. But just because you build the model, you're still not ready to operationalize it, right? There's this whole infrastructure that needs to be in place. So theoretically, yes, you've won. You can get a really interesting publication and you lay the landscape, but we still need to think about machine learning operations, computational infrastructure to actually support a model in real time. How do you extract data from your EHR in real time is another challenge. And then how do you then layer on the cybersecurity, the data governance, how frequently should your models be updating? And retraining, and how do you do ongoing quality control checks, especially in the context of machine learning model provisioning care to a child in this case, which is what we're actually working towards at Sick Kids. And so I think that it's a really exciting time where we figured out data out of electronic systems, and we're now getting to this point, how do you operationalize those models? And that's the real difficult challenge, but really exciting. And I'm excited to dive into that and talk about that more.
Well, thank you very much. I was going to ask you a follow-up question with regards to how it's being received in your own clinical environment. It sounds like you have a very progressive environment. Do you think there is a generational divide and hindrance to the adoption of such platforms across maybe the spectrum of different institutions across Canada and maybe even in the UAE for that matter?
What's really interesting about this question is I think we all have an assumption that there is a generational divide between people of an older generation being resistant to technology. And admittedly, and unfortunately, I had that bias as well, but I think the pandemic has shown that that's actually not the case. A lot of our older generations are quite savvy with technology, are loving virtual care, right? And all of the challenges that come with traveling to your doctor to just get a 15-minute visit. Virtual care has really undone that and is shown as a use case in the adult care populations, that those populations enjoy that type of interaction if they're enabled. Of course, there's other barriers to think through to enable that type of work. From an AI perspective, particularly at SickKids, I mean, you said, I'm in a progressive institution, and that's absolutely correct. It's quite an innovative place, but I think even broadly, what I found is the older generation has this obviously deep, rich understanding of the system and the problem. So sometimes I'll get feedback about, I don't think that's going to work. And it's not because the AI is the problem. It's that the AI hasn't necessarily captured this nuanced aspect to solving the problem, and that we're not necessarily solving the problem in the right way. And I found that has been the rich feedback I've gotten from, sort of the giants of research who are at SickKids, who are in another generation of mine. And when you work in a collaborative way and you tackle those nuanced issues, not only does your AI get better, but I've also found that I've gotten really strong generational buy-in, at least at my institution. And so I haven't had a problem with that, to be honest. And I don't think we will on a broader scale.
All right, thank you very much. My next question is for Dr. Tanya Horsley. So in follow-up to Dr. Singh's comments, Tanya, you recently contributed to the Royal College's Task Force on Artificial Intelligence and Emerging Digital Technologies. What did you learn as part of that work about training of health professions, specifically medical education?
Yeah, thank you. And I want to echo Dr. Singh's comments. Thank you for the invitation and for that nice introduction. I think this really builds, I think it's a great question, really builds on Dr. Singh's comments that, he called out that there's this, this infrastructure that needs to be built. And I think that infrastructure needs to be complemented with a strong and robust training and learning approach for physicians, who will really be at the coal face of development and implementation. So perhaps before I make some reflections about the learning and training needs, maybe just to contextualize what the task force was for some of the audience. This was a group of 15 global experts in AI and physicians who were really commissioned to think strategically, at least in Canada, around how do we prepare our trainees and our current physicians for the pervasive implementation of AI and digital technologies so that it can actually improve patient care in Canada. And it really was to think about strategic recommendations around training, around education, and of course, system delivery. As part of that, and I'm going to situate my comments about the education and training needs really around a survey that we did of our fellows. So we surveyed 5,000 of our fellows and simply asked, how ready are you? What kind of conversations are you having in your environment? And I think the findings are quite surprising and really dovetail nicely with what Devin said about the sort of generational divide. So I think one thing to note is that most fellows who responded to our survey really find themselves ready to adopt AI now and in the future. There's a readiness to do this. But what we found was this gap in understanding. Most of our fellows said, I actually self-identify as someone who knows very little about AI and digital technologies, but I want to learn more. And so there was this sort of disconnect, this readiness to want to contribute to development and implementation, but really not having a good, rich understanding about those foundations. And I think secondarily, what's important to call out as well is that many of our fellows had said, in my environment, we are not talking about AI. Even though I know it's around me, we're not having these thoughtful conversations. And so one of the, I think, important callouts from one of our key stakeholder interviews, Joshua Bengio, he said, we really need to rethink the training of our fellows and our residents. It could be that specialists are trained in such a way that they may need to switch to another specialty throughout their career. And so what does that look like? And I think because of the nature of AI and digital technologies, we really need to think about new fundamental competencies. So part of that training is going to need to include things like digital health literacy as a fundamental. And this is really, for those of everyone on the call, we really define that and situated that within the WHO's definition, which is, it's that ability to seek and find and understand and appraise health information from electronic sources. And so the college is starting to make a commitment to this by really saying our CanMed's competency framework must include digital health literacy competencies for all of our trainees, for all of our learners going forward, to really bridge that gap, that knowledge gap, and that implementation gap that we saw from our task force.
Tanya, would you say the gap is a chasm or is it a minor valley? How would you characterize that gap?
Yeah, so I think it's probably somewhere right between chasm and valley. So if I think back on our data, and I hopefully I'm quoting this correctly, nearly half of our fellow surveys expressed a high level of interest in participating in education, but nearly 65% said they had very little knowledge of AI. So, there's quite a large education gap that has to be filled. And we did survey our respondents and say, like, what is it that you would need? It's remarkable. Most of them said, simply, we need foundational AI. Like, what is AI? So I think we're at a sort of a precipice here that we need to start at the foundation and build. But I think that chasm can be minimized fairly quickly.
All right, thank you very much. I'm going to pass the next question on to Jacqueline Duvoisin from Think Research. So you are providing evidence-based clinical knowledge for clinicians at the point of care. How do you see AI impacting health profession training and delivery of patient care? And how important is that relationship between vendors such as Think Research, those technology companies, and the clinician community to ensure that that human element in developing AI is certainly captured and incorporated into those product offerings?
Thank you, Greg. During the pandemic, we have just seen how vital technology is in healthcare. For example, with the boom in telemedicine, people are demanding more access to and control over their healthcare than ever before, and this is made possible through innovative solutions. The difference AI and related technologies will make to health professionals is that they will have not only the newest reference material for their clinical decisions at their fingertips, but that these same digital supportive systems will customize the information they provide to clinicians. This means the guidance will be personalized to the patient's medical history, improving results and the quality of care provided. This level of assistance will increase the accuracy of diagnosis and also offload and speed up time-intensive processes that, for example, a primary health physician handles, such as analyzing medical imaging. Regarding the human element, ensuring the doctors understand and trust new medical technologies, it is always a challenge. Even going back to when electronic health records were introduced. These are factors that have to be addressed in how AI technologies and products are designed. They cannot be developed in a silo, but must address both the medical problem AI is trying to solve, and on the other side, also the real world context in which medical professionals are going to use them.
Great.
Yep.
So when it comes to some of the major hurdles, maybe you can just reiterate what you think are the major hurdles when it comes to introducing this technology to the clinical environment.
Yeah, good question. The common hurdles are, of course, the adoption. Just because a new technology is introduced does not mean it will be immediately used or even used fully. A much bigger hurdle can be the changing decision-making routines. Clinicians, through their medical school education and years of professional practice, have well-defined ways of making decisions that do actually not always involve AI-assisted guidance.
All right.
Thanks.
All right, thank you very much. I'm going to ask Dr. Anese, who is a practicing gastroenterologist in Dubai. You've somehow or somewhat pushed the boundaries, I guess, within your profession using some technology, robotics to collect data. Maybe you can enlighten the group and the audience as to what you're doing with technology to treat your patient community.
For the question, for the invitation, and for a great introduction. Well, indeed, we faced with technology since a while, especially for endoscopy in the GI. And I remember when we started endoscopy, we just basically seeing the KO with fiber optic instrument. Now we have 4K, 5K video with digital filtering. So it's a great progression there. And we are also moving to a so-called smart capsule, not only the capsule for the endoscopy, but smart capsule that go through the GI tract to capture a number of information. So well, and the patient accept very much this evolution. Talking about artificial intelligence has been proved experimentally since a while. It's on the market now. So we use as a help for the endoscopy, for example, to detect very minor lesions, to help the endoscopy when it can be fatigue after hours of activity, and so to maintain the same standard, for example, in the detection of polyp, or detection of very minor lesions. So these are the great progress. And in the field of robotics, for example, I've been pioneering the activity of a spin-off in Italy, in Pisa. We have developed together a kind of disposable colonoscope that is remote controlled with a joystick, and it's completely painless because it propels itself along like a e-worm. And that's really a great innovation because, well, theoretically, the patient itself can move the scope within his intestine, and he can enjoy to have a kind of evaluation completely painless. And this will also give the opportunity to a number of people then so far don't do endoscopy, even when there is important indication, for example, the presence of blood in stool, because they are concerned about the pain or concerned about the sedation. So there will be no pain and no sedation, and there will be an excellent exploration.
Excellent. So there was probably very little skepticism on the part of the patient population to, I guess, adopt this type of a treatment protocol. Was there any skepticism within your community when you started to introduce the robotics and those types of diagnostic tools? Oh, we might have lost Dr.
Now I can.
Okay.
Now I can.
Okay. Oh, did you hear my question? Okay, you can hear me now?
Fine.
I was just asking about when you started to introduce this type of technology in your practice, was there skepticism within your practice group? Was there skepticism on the part of the patient population, or was it fairly well welcomed and received?
Well, any change requests some sharing of experience and some demonstration of efficacy. Specifically, the increase of safety and the increase of efficiency and the patient satisfaction is a kind of course, is combined with the success of any kind of technology. And especially for this kind of robotic application, there will be a great acceptance for the patient. The learning curve takes a while. And so normally an endoscopy can do a colonoscopy in 10 to 15 minutes at the beginning of practice with this kind of joystick movements. Okay, we can take longer, but we can teach even remotely. So we can teach on model to achieve a kind of practice that can approach the same time that we need for a standard colonoscopy.
Great, thank you. I'm going to go back to Dr. Singh. In preparing for today's session, there's been a lot of written material about the digital divide, inequities in healthcare delivery. And I'm wondering, from your perspective, do you see artificial intelligence closing that gap or creating an even broader chasm and greater inequities in the quality of care or the access of care to certain patient populations?
Greg, that's an outstanding question. And the answer is really complicated, actually. The answer is both can occur. And I think it's really going to depend on how leaders in healthcare, leaders in government, and how industry leaders enable the deployment of AI and machine learning and just technology abroad in healthcare. So for example, my startup Pure AI is creating this incredible front-end AI platform architecture to enable clinics, hospitals, to connect to patients in ways that have never been done before. It's really awesome stuff. However, you do need access to internet. Right. So right now, if we were to deploy all across Canada, if you didn't have access to internet in your home, these patients would be left behind. We're doing a lot of efficacy research and impact analysis to demonstrate how impactful the Hero AI software is going to be, which is incredible. But then that's simultaneously proving that we're going to increase the healthcare divide. And so the moment we started to realize the true potential of machine learning, both from an academic perspective and an industry perspective, I started to realize that there's a real problem on the horizon here. Something as simple as reliable high-speed internet connectivity, particularly in our northern communities in Canada, and I'm sure there are communities surrounding Dubai that have a similar challenge potentially. We will leave those folks behind. And so from a government, from an advocacy perspective, even from the way that we innovate on how do you deliver like internet technology to these communities, we need to figure that out in order to remain equitable. So that's one piece there that's tricky, and that requires advocacy, I think, from the healthcare group and the computer science group together. The other piece is around the way we build our machine learning models. And are we actually performing the necessary bias assessments to determine that the models are equitable across all groups? For example, we have probably one of the world's most diverse populations in Toronto, Canada. I'm very proud of that. That means that we actually have an incredible population for building machine learning models, like incredible. I build these models in the emergency department at SickKids. I see as an emergency doctor the diverse population, but my models don't see that because I don't have ethnicity or race as a label within my EHR. So what does that mean? That means that I train my models. I can do gender bias and make sure it's equitable. I could do age bias, make sure that's equitable. I could go postal code, maybe by language spoken, but I don't have ethnicity. So currently right now, the reason why we're not deploying these models at scale, even though we're nearly ready to, is because I can't look to our Canadian population or our international colleagues and say, the models I've trained are not racist. These models are equitable for all populations. Another thing we need to start thinking about is gender and different gender labels and non-binary gender labels and ensuring equity is captured there. And so that is a real barrier. And if we're going to take AI and ML equity seriously, we need to start capturing that data right from the beginning in our health records. The US does a great job at capturing that actually, but in Canada, we're innovating on that right now rapidly.
Is it a question of privacy, security, legislation that needs to change in order for those data points to be captured, or is it just some other factor that I just not aware of?
Yeah, I think that we actually have mandates now in Ontario to capture this data and to integrate that capture process in our EHRs. So I think the value of doing this is definitely heard, and people are working incredibly hard to do that. And so I'm not worried. I think it will come to fruition. What I do is I just bang on the door every now and then and say, where's the ethnicity label? And I sort of light fires every now and then in some of my presentations to speed the process along or to highlight that this needs to happen with prioritization. But at least in Canada, that process is happening. And I'm not sure, it'd be interesting to hear from our colleagues in Dubai, is that type of information captured in your EHR? I'm actually not sure.
Right. Well, maybe I can throw this question over to Jacqueline or to Vito. Following up on Devin's question, are you capturing this information? Are you allowed to capture this information in the UAE? And also my second question for Jacqueline will be, from a technology vendor perspective, data integrity, security, and privacy are all paramount issues. Everybody's concerned with the privacy and security of their data. So what is being done to protect this data? As more and more data is being collected, the risk must be going up. And we want to make sure that the patient is protected, the clinician is protected, and the institutions that are delivering the care are also protected. So maybe we can get your slant on that, Jacqueline, as well.
I will leave the data with the question with the data capturing to Dr. Vito, as he is more in the front line than I am. Okay. That's for sure. Data and privacy is extremely important, and that's a really good question, and that's certainly paramount. So we at Think we take this very, very seriously. Our solutions are developed with protecting patient information in mind. But when you're sick or need care, the last thing you really want to worry about is the security of your data. That's why it's so vital that when we develop and design technologies, we are thinking about protecting this patient information from the start. One of the key considerations with patient data from the point of view of a vendor is ensuring that data privacy and security controls are factored into the decision-making process when designing, creating, and implementing digital healthcare products. This means, of course, ensuring that the data collection and storage is aligned with the relevant health laws in the jurisdiction, and also ensuring their internal team members reviewing for data privacy and security. In our company, I think we have a privacy legal officer and a privacy review board to act as the watchdogs to make sure that nothing is left unprotected. For example, to make sure that how and where we store data does not clash with our legal and contractual obligations. As the volume of patient data increases, and as we are seeing it used in novel ways such as aggregated analytics or predict healthcare trends, it is even more important to make sure that checks and balances are in place so that health data is handled properly. Thank you.
Thank you very much, Jacqueline. I'm going to go to the chat box and address some of the questions that have been coming in. Question for Devin. You've highlighted a core limitation with artificial intelligence in all its applications, not just in healthcare, getting the right scale in terms of available data. In your opinion, how much data is sufficient? Aside from the major metros in Canada, will there be enough data for an application in smaller areas, particularly in the north or in even less populated areas like the UAE? So I guess it's a question around data set size and validity of the algorithms.
I love this question. I could talk for like 2 hours on it. I'm like really trying to rein my brain in to give a succinct answer. Right. So I would never go into a problem with thinking, oh, I don't have enough data, and don't make that assumption. You should ask the question now, we have this workflow problem in our hospital. Can we use machine learning? That should be, you should just always ask that question and think about it and have people on your team who can help you answer that. But for example, we had a massive workflow problem where kids who had craniosynostosis or a head-shaped deformity challenge were getting referrals way too late, and there were delays in their processing. They were missing this ideal surgical window, which meant that they needed more invasive surgery. We only had like 600 data points for these kids, right? Because it's a relatively rare disease. We took 3D images of these kids. There's only 600 of them. And we assumed, oh, we could never solve this problem with machine learning. But the signal was so clear in the data. And so this is the real learning point here, is that if the problem is really clearly evident in the data and the data captures that signal really nicely without much noise, you actually don't need that many data points to solve a problem. We were able to build a machine learning model with a 3D neural network application onto these 3D images to predict which of these kids actually needed surgery. We used that as a leaping pad to win a grant for $500,000 from the Canadian government. We're now deploying this onto mobile phones out to community clinics. It's an incredible win. But if we made the assumption that 600 data points was never going to be enough, we wouldn't even have got there. So I would challenge people not to limit yourself by saying, I don't have enough data. Really, the question is this a problem where when we as humans look at this data, it is really obvious that this maps to that? If you can say that that's true, then the amount of, you don't need this big data set with millions of data points. If you can say that that's true and you're looking for something a bit abstract that's not so clear to human, then yes, it might be more challenging. You may need a larger data set.
All right, thank you very much. I have another question from Syed Zaman, who is asking about drug discovery and artificial intelligence. Now, we don't have someone from the pharmaceutical industry on the call, but maybe I can frame that question of how do you see AI shaping drug discovery or even tailoring patient care? And how far are we away from that bedside tricorder that we've seen so often in Star Trek movies to really shape the care and diagnosis of patients? Is that far-fetched sci-fi still, or is that current present day? Maybe I'll start with you, Dr. Vito, and how you feel artificial intelligence is shaping delivery of care, and then I'll throw it over to you, Dr. Singh.
If I may comment on that, the reality is here already in the system biology. There is a number of research with translation, with use of learning machine and any kind of sophistication, any difference of kind of artificial intelligence to predict the efficacy of medication and to predict the toxicity of medication. And that will be probably the way to go for the future. This is already the reality in oncology, and it will be the case of the majority of immune-mediated diseases. So there are the instruments there. So it's just a matter to capture enough data. And on the contrast of what was just saying the colleague, indeed, sometimes the statistician love to have more data. So more data in, more complexity of analysis, and probably more sophistication in the answer.
All right, thank you. Anything to add, Dr. Singh?
Yeah, and so I think this is, like, I totally agree that for this particular problem, you need more data because it's not clear. You're like swimming in muddy waters. You're not sure where you're going to go. And so in these instances, actually, lots of data is necessary. I think the value that AI brings is just the speed at which it can help connect the dots for you, right? So what once might have been a somewhat manual process, and even if just this is all manual and we use AI to automate a segment of that, we target the bottleneck of drug discovery and use machine learning to automate that, or even to lower the cost of drug discovery would be an incredible thing if we can put drugs out onto the market that are more affordable and accessible to patients. AI is going to enable that that discovery process, but you would need a lot of data. It's the opposite of what I just said.
Right, excellent. I'm going to go back to Dr. Tanya Horsley. I want to talk about the ethical concerns around artificial intelligence. The work that you did with the Royal College's task force, what perspectives did you gain from that work regarding the greatest concerns within the specialist community when it comes to training and the ethical implications of introducing artificial intelligence into the care model?
Yeah, thank you for that question. I think it dovetails really nicely with some of Dr. Singh's comments as well. And I just want to apologize too about my video. A few people have asked to have it turned on, but it's a little unstable. What we learned from the task force was that ethics and legal considerations are top of mind. So if I look at some of the data that came out of our survey, we had asked our fellows, if the Royal College were to develop educational content, what are some of the top topics that you would want to hear about? One of them I've mentioned already was just fundamental basics of AI, so technical training related to your specialty. Ethics and legal considerations, things around health privacy, liability, we're all in a litigious environment, things like human rights and certainly patient consent were ranked number 2, which was a bit of an aha moment, I think, from the data for the task force members, but very, I think, important to sort of call out that this is an area where the Royal College is really developing some educational content for fellows. But I think if I was to situate this a little bit in Canada, and I'm certainly not a legal expert, nor am I an ethicist, but I think the conversation in Canada and probably in Dubai as well is that any ethics and legal matters tends to lag behind technology development. And Devin and others may have more comments on that. We're certainly involved with a project now, really looking at, what are the conversations about legal matters related to AI globally. And we do note in our report that one of the challenges, at least in Canada, is that even though there is some current governance, so legal, policy, and ethical frameworks, that they may not be agile enough currently to support the adoption of AI into healthcare systems. And so the task force really called out this need to provide training, not only to physicians, but if we want physicians to be in co-development, co-production of AI, that training needs to extend to engineers and research scientists and software designers as well, like Devin and others, so that they're working in concert to develop these technologies. And again, these ethics and legal considerations are considered sub-competencies that would need to be defined within our CanMeds framework. And so the formal recommendation from our task force is that we have to collaborate with partner organizations, not just alone. This is something that has to be done in development with others to really tailor and curate and distribute educational offerings in this space so that we can, again, move with those governance structures and legal and ethical models that are going to emerge in terms of AI and technology development.
Thank you very much. I have a couple of questions from our panelists. Dr. Lonekar is asking, how can a totally new physician start his career in artificial intelligence? What kind of training, qualification, is desirable. I guess this speaks to, what's the first step for that journey that you would take or encourage? Maybe Dr. Devin and Dr. Vito, you have some words of advice given your clinical practices, and where did you start, lessons learned, and how to get ramped up into AI? Maybe we can share that with Dr. Lonekar.
Yeah, I can go first because I didn't have a computer science training background prior to my AI journey. I saw AI as being this way to solve a particular problem in our hospital. And then the more I looked into it, I fell in love and became obsessed with figuring it out. So how did I start the journey? There's a ton of content online, first of all. And so if you're interested in even learning the programming aspects of it, like I was, there are so many free courses online, YouTube videos. I used to watch literally YouTube, like these high school kids programming in Python on how to build machine learning models. There's lots of healthcare data sets out there as well that you can start on. And they literally walk you step by step by step on how to take the sample data set online and build your own machine learning model. So I found that to be really powerful because as I was building, I was starting to learn on my own a bit of the theory. And it made me connect the dots and understand that AI isn't this abstract thing. It's actually just a bunch of code with some math embedded into an algorithm that spits out a probability. And it's combining those two efforts of learning the introduction to coding, reading through some of those online tutorials, and then reading about what is machine learning, the categories of machine learning that got me started. And I think at that point, you can actually make a decision to say, I love coding, I'm going to dive right in and learn it. Or I don't love the coding part, but I really love the theory part and I see the potential. I'm going to understand the theory, understand how to read AI literature in healthcare, how to become a critical evaluator of machine learning, and then facilitate the adoption by bridging the gap between your clinical experience and another computer scientist. So I think that's a really great approach because you don't really know until you start to wet your feet.
Right. Thank you very much. Dr. Vito.
In the School of Medicine, so far, there is not a specific approach on that, but there is a number of masters in some university in mathematics or statistician. They combine the artificial intelligence evaluation, and they are really keen to integrate the crosstalk with other specialties. So there is a great opportunity there, across other faculty to get that kind of master.
That's great. And Dr. Horsey, from the Canadian perspective, do you have anything to share?
Yeah, so I think there's growing interest, and I think there's many people, we talked about that readiness to adopt and be involved. And the college is currently considering whether or not we need an area of focused competence, what we call an AIFC. This is a concentrated area of expertise, or even a new discipline, so that there would be formalized training. And this is going on. Maybe Devin and others can speak to this. They had this in the US already. It's starting to be developed in Canada, but the college is recognizing that there is this bolus of physicians who want to train up and become more expert and actually lead in their institutions, be those go-to people in their environment. So the college is already thinking about developing these competencies and frameworks so that we can train individuals who have a heightened interest in actually making this a part of their professional career.
Yeah,
Exactly.
and just building on that real.
Oh, sorry.
Oh, sorry.
Go ahead.
I was just going to build
ahead
on that really quickly to say that, a year over the last few years, I've had like 20 to 50 people reaching out saying, I'm interested. I'm a physician. I have no computer science background. I'm interested in AI, right? Looking to dive into it. And it just sort of reflects the lack of a formal process, at least in Canada, on how to navigate. There's different informatics masters. The computer science masters is incredibly intense and difficult to get into. And then there's no fellowship training that's official, a part of that. And so the interest is there, and there's a really great opportunity to capitalize on it.
Jacqueline, do you have anything to add to that question?
Yeah, it just came to my mind that perhaps companies who develop healthcare solutions, technology solutions with whatever content it is, ours is now clinical, we always need physicians and clinicians and pharmacists to basically make sure we are not developing in silos. And that would be another part where you could learn, basically learning by doing, and then slowly get into it.
I was just Googling, there is 74 Master of Science program in AI that you can find on Google.
Craig, I also want to extend Jacqueline's comment and Devin's as well. Sorry, this is probably one of those areas where many of us have comments. But there are many programs now developing, and I know that there's one in UHN in Toronto where they're developing a mentorship program. And this mentorship program is not designed for someone who wants to, develop their own technology, but it teaches physicians how to interdigitate with developers. So what's that language of engineers? What's the language of a developer? What is the MBA, the business model side? And so, to Devin's point and others, there are many entry points into being involved with AI. And I think the Royal College, at least I can speak from that perspective, has a great opportunity for taking the nearly 48,000 physicians who may want to be interested in this and finding those entry points and pathways to being a part of the AI experience and implementation.
Right. From a funding point of view, do you think it's adequately funded across the healthcare training and delivery spectrum? Is there a funding gap that needs to be closed? Or, I mean, everybody always wants to have more funding, but right now, do you see it as being a hurdle that needs to be overcome to advance further and faster? Maybe I'll start with you, Doug.
Yeah, I think the funding is there. I think the real hurdle, obviously, like you said, more funding, great, is the better. I think AI will start to demonstrate its return on investment. So the funding will follow. I'm not actually too worried about that because I'm confident in the ROI. I think the biggest issue actually goes back to what Tanya was saying around the ethics, the governance aspect of things. I think we need to de-risk machine learning by creating, more standardized infrastructures on how do you choose a machine learning model to integrate into your hospital? How do you critically evaluate that model? What are the parameters around liability and the legalities and all of this stuff? What are the data governance best practices and cybersecurity best practices? To me, what I'm seeing, at least across Toronto, is that those are the real barriers to trying to deploy quickly machine learning into healthcare. It's these leftover questions and uncertainties that creates perceived risk, and it's a real risk actually to institutions when those answers aren't solved. And so a lot of institutions like SickKids is putting an incredible amount of work in solving out those different pillars of support to then layer machine learning on top of. It would be nice if there was national guidance on best practices for hospitals or the average community clinician even to follow. So that they can utilize ML safely and at least feel safe in doing so.
All right, thank you very much. In the final few minutes that we have, I'd like to go around the horn and just ask for some of your closing comments and thoughts around artificial intelligence in healthcare. I'm going to start with you, Dr. Horsley. Maybe in 30 seconds, you can share your words of wisdom for all the registrants today.
Sure. I mean, I think we can develop a lot of technologies. We've heard of the tsunami of technology. I mean, AI is here. If we think about it's something in the future, it is now. And I think if we want to have seamless, frictionless, ethical, transparent implementation of AI, we have to ready the physician workforce to be at that coalface, really working with patients. And so one of the fundamental foundational, I think, learning or educational approaches that we need to have is, it's not that our physicians have to know how to code. I mean, that came out of our task force pretty clearly. It's not about coding, but it is that ability to really speak to a patient at a level that is explanatory, that is lay, that is approachable. And so how do we train all of our residents and our 48,000 physicians to feel comfortable with having those conversations with patients so that they feel comfortable and secure in their care experience, particularly when it involves ML or any digital technologies.
Great. Dr. Nesse, same question to you. Final comments you'd like to leave the audience today? Dr. Nesse, can you hear us okay? Oh, I guess he can't hear us. So we'll go to you, Jacqueline. Do you have any closing comments you'd like to pass along to the audience?
Yeah, AI and advancements in technology will continue to better the healthcare sector and allow for more personalized care. Our business is purpose-driven, and our mission is to organize the world's health knowledge so everyone gets the best care. Technology and AI is a part of that. And while a personal relationship to a clinician remains incredibly important, equipping healthcare providers with technology to do their job as efficiently and as effectively as possible is really key. And then that said, we must continue to have safeguards in place to protect the patient data, ensure the privacy and security controls are factored into the design from the start. Thank you.
All right, thank you. Dr. Anese, do you have any closing comments?
My comment is the AI is already the daily practice, I would say. So already AI can do better than many radiologists in terms of evaluation of imaging. It can do better than many dermatologists to detect skin lesions. The point there is to keep humanization. So, well, the connection with the patient, the clinical practice with patient. And the other great point also to maintain the private security, because this already raise ethical question when there is this diffusion of data.
Thank you very much. And Dr. Singh.
Yeah, sure. I think the closing comment that I would want to leave is that we need to remember that all of this technology is really cool. It's outstanding. It's exciting to work on. But at the core of all of this is that human element. So we need to remember that we're building technology to enable humanity and this human connection. And it seems counterintuitive because we sit in front of our EHRs and our computers and we're like this and the patient's over here and it makes no sense. But I really believe when machine learning and AI starts to take off, it will enable that human element if we don't forget about it from the get-go. And this needs to come from clinicians. It needs to come from academic institutions like SickKids or companies like Hero AI need to embed that human element into everything they do and understand their patients and capture that nuance to enable great care.
All right, thank you very much. So that's going to have to conclude our session for this morning. We're very close to the final few minutes. I want to thank Jacqueline Duvoisin, Dr. Vito Anese, Dr. Devin Singh, and Dr. Tanya Horsley for giving their time today. I know you're extremely busy, but this is very much appreciated. I want to thank all the attendees that registered and participated today. There was about 6 or 7 questions that we didn't get to, so we'll try and facilitate some answers and share them with you in the future. I want to thank the Canadian Business Council, Dubai and Northern Emirates for putting this on and all the sponsors. We want to keep the conversation going. You may have some contacts within that list of participants that you can reach out to and share additional questions or keep the conversation going. I know there's a lot of interest in AI and healthcare, so let's not make this the final conversation. We do have future panel sessions coming up, so we're always looking for topics. Please forward them to my attention or to Diane or Rada's attention, and we will try and get them on the agenda. And with that, I would like to say thank you very much for your time today. Stay safe and stay well, and all the best, and we'll see you at the next session. Thank you very much.
Bye, everyone.
Thank you.
Bye-bye.
Bye.
Thank you.
Thank you.